day everyone, and welcome to our endoscopy suite here at Leiden University Medical Center. So today we are going to treat a patient with familial adenomatous polyposis, or FAP for short, and she has been diagnosed with an adenoma of the ampulla of Vater. We're going to evaluate it with EUS and then treat it with ampullectomy if deemed safe. So we're going to do that under deep sedation. So we have Vincent taking care of the patient. The devices that we're going to use today, first for the EUS, is the Arietta 850 ultrasound device in combination with the 740 UT excellent echo endoscope from Fujifilm. Helping me in this procedure are Marianne and Mariska, our endoscopy nurses, aiding me in resecting this polyp. So let's start with the evaluation first. So we have the patient already in a prone position, so prepared for ERCP. So first introduction into the corpus of the stomach. And as you can appreciate, she has many fundic gland polyps. So first, before the evaluation of the ampulla, I will take a quick look at the pancreas to see if there are no intrapancreatic lesions. I look for the aorta. So I pull back the scope to a distance of 40 to 45 centimeters from the incisors, and then I try to find the celiac trunk. I already had a glimpse of the pancreas, but we'll do it in a structured way. So we see the aorta here down below. We'll see if we can find the celiac trunk branching off. That is just here where the arrow is. We follow the celiac trunk for a bit, jump over the celiac trunk, and here we fall up on the pancreas. I'll zoom in a bit. You see the pancreas just below the transducer with the pancreatic duct here down below, measuring, I think, just in over a millimeter. So that is normal. So when we place the transducer towards the apex of the duodenal bulb, you can see the portal vein right here. Here you can see the pancreatic duct, and also here the common bile duct coming here from the liver, running through the pancreas towards the papilla. So this is the common bile duct. Here is the pancreatic head. You can also see the pancreatic duct here running down below. So no dilation of the pancreatic duct, no dilatation of the common bile duct. As you can see, there is a ampullary adenoma. The ampulla is a bit too large for what it normally should be. And in a second, we can also assess the ampulla with our duodenoscope, but also with this 740 UT, which has an angulation of about 40 degrees. You can also appreciate the ampulla quite nicely. And in some cases, you can even do ERCP with the duodenoscope. And in order to appreciate the ampulla fully, we're going to insert a couple of syringes of water inside the duodenum. Usually 3 is enough. So here you can see the right kidney, and if we move the endoscope from counterclockwise to a clockwise position, you can see the ultrasound view going from the right kidney to the cable vein here down below. Here you see the lumen of the duodenum, and here above the duodenum, there the head of the pancreas should be. So we pull back a bit, and running below the pancreatic head are the superior mesenteric artery and vein. So these delineate the pancreas. We pull back, and we try to find the ampulla with the PD and CBD running through them. So here you see the pancreatic duct running through the ampulla. And let's see if we can also see the CBD that's right here. A bit more difficult to see that one running through the ampulla, but this is the lesion. You see the muscular layers here down below. And if we have a look at the mass, it doesn't seem to grow into the duodenal wall. So the layers are nicely respected. You see the PD, CBD running through, but no ingrowth here in both the ducts. So I think we can resect this adenoma, which has previously been staged as low-grade dysplasia, but it has been growing for a couple of endoscopies. The patient's main physician decided that it's time to have the ampullary adenoma resected before it becomes even larger or may develop any signs of high-grade dysplasia. So we'll switch to ERCP. First, we're going to perform pancreatic cannulation, so that we really know that we can stent the duct after resection of the ampulla, and then we'll go for the resection of the ampulla itself. So we had a bit of discussion with our endoscopy nurses a minute ago, and well, as you can see on the endoscopic view, the position of the echo endoscope towards the ampulla is actually, well, rather favorable, and I think that also cannulation without switching to the duodenoscope can be done. So let's see if we can get a wire inside the pancreatic duct with our echo endoscope. That seems to be going inside the CBD. Let's have some contrast in there. Yeah, that is CBD. Also quite handy to have an image of that before the ampullary resection. We would like to have a short PD cannulation, because after the resection of an ampullary adenoma, the chances are up to 15% of post-procedure pancreatitis, and also on the long-term risk of stenosis of the orifice of the pancreatic duct. So I'm trying to inject some water. So I think we have to be a bit lower, because you see here you see both the ductuli ending up here in the ampulla. So I'll try to orient the catheter so that we align with the lowest orifice. So that seems to be the CBD. Bit lower, bit lower. Okay, come on, we can do this. PD cannulation seems to be difficult with this approach. So we'll switch to the duodenoscope, have a short attempt to cannulate the PD with that, and otherwise we'll go for ampullary resection otherwise. So here you see the ampulla again, a bit different orientation with a real duodenoscope, where we view the ampulla a bit from above. You can see it genuine side viewing with a duodenoscope. We'll try and see if we can identify the pancreatic duct orifice for a sec. If that doesn't work, then I think we should move forward to the resection of the ampulla and then do the cannulation of pancreatic duct afterwards. It's also possible that the pancreatic duct exits at a different section here. What is this? Let's see. Yeah. So what we couldn't really see earlier is that there is a tiny orifice on the side of the ampulla, which is actually the orifice of the pancreatic duct. So now we're inside the pancreatic duct. Give some ERCP contrast mixed with methylene blue, so that we can backtrack the orifice after the ampullary resection. Okay, so we're going to remove the guide wire as well, and now we go forth with the resection of the ampulla. We're going to do that with a small polyp snare. We're not going to inject any lifting fluid below the papilla, because there's no use for that. You can't lift the papilla because the PD and CBD run through the wall. We can slide the snare over the upper part of the ampulla, and you want to make sure that you really have the entire ampulla papillary complex. So we have to land the snare over here and then have it closed at the bottom part down below here, so that we also have this bit of neoplastic tissue on the bottom part of the ampulla. So let's try and position the snare. Open the snare. I think I'm going to take that fold with me as well. So slowly let it slide over the ampullary complex. The snare is fully opened. We move the scope a bit down under the level of the ampulla. And we'll make sure that we have the entire ampullary complex. So let's close it slowly. Maybe a bit difficult because I'm using the elevator a bit. Yeah. So now we have the entire ampullary complex. The upper side seems to be in, lower as well. Okay. Now we use the ERBE generator. We use the small polyp settings for resecting the ampulla. As soon as we have it off, we're going to take it out with a net and go in, because the first bleeding occurs about 2 minutes after resection, if there is any bleeding. Okay, so we're going for the resection right now, applying current. And it may take much longer than you're comfortable with. It may take even 10 seconds or longer if it's a big polyp. Okay, it's through. We're removing the snare. We're going to advance the net. So here it is in the duodenal bulb, and a very awkward position. So it's a bit difficult to get net over our specimen. Okay, let's close the net and see what we have. We have something. Okay, well, going to pull out the scope for a sec. Here it is. Seems to be fully intact. And here we are back in the descending part of the duodenum with our duodenoscope, so we can inspect our resection margin. So at 12 o'clock you have the CBD, which is quite yellow actually. Now we're going to see if we can find the opening of the pancreatic duct. I think it's just a couple of millimeters below the CBD entrance. No bleeding. And here, I think if we have a look at the resection margins, I think we have the entire ampulla. Right here, where there is still a bit of blue, is the pancreatic duct orifice. Let's see if we can find the PD. We seem to be in there, but we have to find the main pancreatic duct and not get stuck in all the side ducts. So there's our main PD. It would be quite handy if we can get rid of that loop. Yeah, so if we have the stiffer part of the guide wire in the PD, then it's possible to also place a pancreatic stent. That's a side duct. Okay, so get the guide wire in the true main duct. Now it's all upon the skill of our endoscopy nurse. Get the guide wire deeply in so that we can safely place a pancreatic stent. Now you can have some discussion about what type of stent you want to place, because we want to prevent post-ESGE pancreatitis. So usually a soft, short plastic endoprothesis would be enough. In my humble opinion and experience, these stents tend to migrate even minutes to hours after your procedure. So I tend to place a bit longer pancreatic stent. Yeah, okay, do a long exchange. So I think in this case, I'm going for a 5 French, 12 centimeter Zimmermann plastic endoprothesis. It's fenestrated and has an anti-migration flap. Another question is, should you also stent the CBD? Well, data shows that there is no real need to do so because the pancreatic duct has the risk of fibrosis because it's quite small. That tends to not happen to the CBD. So as you can see, all the contrast that we injected in the CBD has all but gone. So we'll stent the PD and we will leave the CBD orifice alone. Well, the attentive viewer among us may have seen that there is a bit of contrast alongside the pancreas. So we may have caused a guide wire perforation. So I think that's a good idea that we place a somewhat longer pancreatic stent for adequate drainage. So we're inserting the pancreatic stent right now. Here it comes. We open the elevator, and there's the anti-migration flap. That goes in quite nicely. So we add some fluoro. Here's the metallic band that indicates where the pigtail starts. So we pull back a bit on our wheel. We back up with the endoscope, also pull back on the guide wire. And here you have it. We have our pancreatic stent nicely in place. So we can leave that up until our next evaluation. So no active bleeding, that really tense hemostatic measures. Okay, we're going to leave that as is. And this is a demonstration of evaluation and resection of an ampullary adenoma.
So, a happy end after ampulectomy then? Well, in the night after the procedure, our patient developed melena, hematemesis, and a significant drop in hemoglobin. Therefore, we decided to transfer her to the ICU and perform gastroscopy after resuscitation. My colleague filmed the procedure with my mobile phone, so the image quality is a bit different than you saw earlier. Let's see what happened next.